cancer. So he underwent a laparoscopic cholecystectomy on 14 April. At that time, there was no evidence of disseminated disease. There was no carcinomatosis that was readily seen on laparoscopy. The gallbladder was removed in standard fashion without any complications. On the final path, it was consistent with adenocarcinoma PT2 in 0. The cystic duct margin was involved. There were 2 lymph nodes that were examined, and both of those were negative for malignancy. The way that the path report read is, so it does invade the sort of the perimuscular connective tissue, so that's what makes it T2 as it goes through the muscularis. But it's mostly involved on the peritoneal side of the gallbladder, so opposite of the fossa. And then it's well differentiated. So his pathology, kind of all things considered, is pretty favorable in the sense that it seems like it's nodular type in the sense that they measured it at 1.4 centimeters. It's on the peritoneal surface of the gallbladder, so opposite of the liver. It's well differentiated. And the 2 lymph nodes that were examined were negative, so pretty favorable pathology. The fact that it is T2 makes it stage 2 disease. T2 in 0 makes it stage 2 disease, which does have about a 10 to 15% survival at 5 years. So just a little bit about why gallbladder cancer is unique. If you recall the layers of the gallbladder, it lacks a submucosa. So really by the time you get penetrance through the mucosa into the lamina propria and then into the muscularis, you already start to see early lymphatic spread. And so that's the reason why the majority of these that are diagnosed are unresectable at the time of discovery, just because in-2 disease is a contraindication for surgical resection. So just remember that the gallbladder lacks the submucosa, which acts as a little bit of like an insulator against early lymphatic spread. Gallbladder cancer is unique in that there's a couple different ways you can discover it. Probably the most common way, about 50% actually, is discovered incidentally on path. So you're taking the gallbladder out for symptomatic or for biliary colic. On final path, you discover that there's a adenocarcinoma within the gallbladder. 2 other ways to sort of discover this is one on preoperative imaging, which is sort of the algorithm that our patient fell into. And then lastly, incidentally within the operating room, you find sort of direct invasion or something that would make you concerned for cancer in the operating room. So since this is the most common way, this is a nice little algorithm to think about it. So cancer discovered incidentally on histopathology. In that case, when you look at the path report, the 2 most important things to look at is the T staging. So what's the depth of invasion of the cancer, and then the margin status of the cystic duct that you ligated. So just one branch point to always kind of sear into your mind is T1A. So T1A is where you have only invasion into the lamina propria. This has very low lymphatic spread, only about 1%. So the thing to look at is the cystic duct margin negative or positive? If it's negative, you've sort of completed your treatment with the cholecystectomy. If it's positive, then you would need to reoperate. For everything else, T1B and above, it's resection. The only absolute contraindications to resection in these patients is if they have metastatic disease, if they have in-2 involvement, which means like celiac nodes, cable nodes, periaortic nodes, or if they have M1 disease, N2 disease, or if they have significant vascular involvement. And then given the fact that you're going to discover it several different ways, your operation is going to look a little bit different depending on how you discover it. So for instance, with our patient, we discovered, well, we had suspicion based on his preoperative imaging. if you're concerned based on imaging and you have tumor markers to sort of support your suspicions, it is acceptable to go ahead and perform the radical cholecystectomy at the initial operation. It's also acceptable to perform a cholecystectomy and then do frozen sections during the operation to confirm your suspicions. It's also acceptable just to do the cholecystectomy as we did in our case, and then go back for a second operation to perform the radical portion of it, or to perform the liver resection and lymphadenectomy. They found that there's no difference in outcomes whether or not you do a one-stage or two-stage operation. So ours is going to end up being more of a two-stage operation. So a little bit about the surgery. So we're going to perform a radical cholecystectomy to include liver resection and lymphadenectomy, as well as plus or minus a biliary resection. The patient himself is going to get, prior to surgery, is going to get a Foley catheter placed. He's going to have an arterial line, central line for access and blood pressure monitoring. He's going to be supine on the table. We're going to do this through a cochlear incision. To help with the exposure, we're going to use a self-retaining retractor. In talking to the operative team from the laparoscopic cholecystectomy, he's got pretty adequate length on his cystic duct. So the first part of the operation is going to be finding that cystic duct and taking an additional margin to send for frozen section, because that's going to dictate our need to perform an additional biliary resection. So the parts of this operation is one, a liver resection. So the gallbladder fossa mainly resides or lives adjacent to 4B. So if you remember, the segments of the liver are based on portosystemic circulation. Segment 4 is divided into an A and B. So 4B and 5 is sort of comprises the fossa. So that's going to be our liver resection. We're going to do parenchymal dissection using the CUSA, which for the interns or people who aren't familiar with that technology, it's sort of creates sort of a cavitary defect within the parenchyma using ultrasonic vibration, and then aspirates it at the same time. So it makes sort of an atraumatic, or so it's sort of an atraumatic way to do a parenchymal dissection. Even though it's technically a 4B5 dissection, you know, for him it's more practically going to look like sort of creating this rim of, you know, 1 to 2 centimeter rim of parenchymal tissue around the gallbladder fossa, taking care to avoid any of the vasculature or ductal system within the liver. The other part of the operation is going to be the lymphadenectomy. So that includes the dissection of the portohepatis. So in this picture right here, you see some of the nodal drainage from the gallbladder. 2 lymph nodes are already harvested in the original specimen. So the harvesting is mainly going to be around the hepatic and common bile duct, the hepatic artery, and then the peripancreatic nodes right here. So we will do a generous cochlearization of the duo, get some of these peripancreatic nodes right here. You know, we already harvested 2 nodes. A good lymphadenectomy is they talk about 6 nodes. So really just skeletonizing the structures within the hepatoduodenal ligament is going to comprise our lymphadenectomy. It's important to do this lymphadenectomy because for T2 disease, they talk about 50% of the time lymph nodes will be involved. Like I already mentioned, for T1A, it's about 1%. For T1B, it's about 10%. For T2, it's about 50% of nodal involvement at that point. Historically, the dogma was to do port site resection. This isn't commonly done anymore. There's been several studies that have shown that it's not really an advantage to resect port sites during this operation, as that's sort of already an indicator that you have disseminated disease at that point. So we talked about the fact that we're going to send our cystic duct for margin status. So if that's negative, if we send that for frozen section and that's negative, that we're done at that point. If it's positive and we've already sort of reached the confluence of the cystic duct, then we're going to have to proceed with a more or a larger biliary resection. So at that point, we would do a Roux-en-Y hepatochoangioplasty. And the way we would do that is we choose a point about 15-20 centimeters from the ligament of Treitz, bring that loop of jejunum up in an anticolic fashion, and perform a side-to-end anastomosis with the bile duct. We do this with, or I plan to do this with 5-PDS in an interrupted fashion, making sure that the knots lie on the outside. We wouldn't do this over a stent. We would leave a drain. We'll leave a drain no matter what, because we're going to have a raw surface of liver from our parenchymal dissection. If we do a hepatochoangioplasty, we'll probably leave a second drain around that anastomosis. So post-resection, so as far as inpatient stay, the patient will go to the ICU after surgery for close monitoring. We'll do close drain management to look for any evidence of a bile leak. As far as further out, based on what his pathology comes back as for an R0 resection, which is our goal, obviously, he's still going to get frequent surveillance every 3 to 6 months for a couple of years, and then lengthen that out to 6 to 12 months for the remaining years. And then for all resections, he'll be a candidate for adjuvant therapy. We've already talked about several of these studies in this forum, to include the BILCAP study, which showed efficacy of capecitabine-based adjuvant therapy for these patients. So he'll be a candidate for that after his resection.